So if you have a patient that comes to the clinic and you did a Whipple on them for pancreatic adenocarcinoma 6 months ago, and they come back and their CT scan shows a metastasis in the liver, or it shows a local recurrence. Why is that? Is that because we did a bad surgery? Is that because we picked the wrong patient for surgery? Is that because this patient's particular disease biology was bad? It's really hard to know. But ideally, this study showed at least 25, 30, 40% of patients are having recurrence really early on, less than a year after surgery. Ideally, we want to change that. Maybe we can improve the surgery somehow where this doesn't happen. To do that, we made an antibody dye conjugate. So panitumumab is a humanized anti-EGFR antibody, EGFR epidermal growth factor receptor, which is expressed on anywhere between 30 to 90% of pancreatic cancers, overexpressed. Even when it's not overexpressed, this also does work pretty well. And the dye, IR dye 800, is a fluorescent dye in the near IR spectrum with an emission wavelength of 800 nanometers. So in this study, patients get an infusion 2 to 3 days prior to the operation. It's a one-time IV infusion. And then in the operating room, we use a standard Stryker camera to image near infrared spectrum. Then after we take the tumor out, we go image that specimen in the lab on the fluorescent camera. We also image the formalin fixed cassettes and the H&E slides down the line. This is a previous study using this technology from the Lancet in 2020. You could see the tumor pretty well. The first thing this study did was establish the safety of this antibody dye conjugate. There were no serious adverse events reported and 4 potentially related adverse events. And the optimal dose ended up being 50 milligrams. So we moved forward with that into the next cohort. In this cohort of the study, the main goal was, of course, to identify the primary tumor, but also to see whether the tumor metastasized to lymph nodes, to see these lymph nodes intraoperatively, and most importantly, to notice any radiographically occult peritoneal metastases, so metastases that did not show up on the preoperative imaging. We had 11 patients in our study, pretty much all of them with pancreatic adenocarcinoma, 1 cholangio, combination of open and laparoscopic surgery. And we're able to identify the primary tumor with fluorescence in most cases. There's a lot of challenges with intraoperative imaging, one being the operating room being very bright, and other, multiple things can cover the fluorescent signal, including blood and tissue. So there's limited tissue penetration, but you're still able to see the tumor here with a tumor background ratio of about 1.3. When we then take the tumor out and bring it into the lab and image it with the fluorescent camera under more optimized conditions, you see a tumor background ratio of about 1.8. Secondly, you're able to identify some lymph node metastases. It's kind of difficult to see on the bottom panel. You can appreciate the signal is relatively low. When you take that lymph nodes out and you image them in the lab, you can see the fluorescence show up. Now you might ask which of these lymph nodes were actually pathologically positive in this patient. It's actually the hepatic artery, the HA node, and the aortal cable, the AC nodes. And the rest of those nodes were not positive. So it's not actually very apparent just based off of the signal alone, whether or not you had a positive or negative pathologic lymph node. So to try to differentiate this further, I ran a logistic regression model and constructed a receiver operating characteristic curve. And this gave a sensitivity and specificity of about 80%. You can see that the negative predictive value of this model was where the model really shined. So if you're in the operating room and you see a lymph node is not fluorescent, you probably don't need to go after it. And I think that's a pretty good benefit of this technology. Most importantly, you're able to identify fluorescent peritoneal metastases in the operating rooms. This is a case of a diagnostic laparoscopy to start the case off, and you immediately see there are some fluorescent nodules on the peritoneal cavity. These turn out to be pathologically positive for pancreatic adenocarcinoma. And again, you see some ascites fluid. You can see it kind of layering on top of the colon there. That cytology was also positive for adenocarcinoma in that case with a tumor background ratio of 1.2. What I'm really excited about this study is that it not only addresses the fluorescence question, but also tries to address the question of how to get drugs into pancreatic adenocarcinoma. Pancreatic adenocarcinoma is a very, very difficult disease to treat, and most drugs that enter clinical trials eventually end up failing. One of the theories for that is that the drug delivery into these tumors is hindered by the fibrotic capsule. So if you can get a drug into the tumor and study why this is happening and what the barriers are to this happening, that would be great. We have a model that does that because we have the tumor lighting up from an IV delivered drug. So you can see in the left panel that the tumor cells are fluorescent. In the middle panel, you can see the RNA expression of all the cells surrounding those tumors. And on the right panel, you can see all the proteins that are surrounding those tumors. So if we can correlate which cells are the barriers to drug delivery, that would be a major advance for pancreatic adenocarcinoma. And we have this ongoing for all of the samples in the study. So I hope I've convinced you that we can use this technology to identify the primary tumor for patients with pancreatic adenocarcinoma, also lymph node metastases and peritoneal metastases. And I hope I've gotten you interested in the drug delivery part. That's coming soon. And of course, I'd be remiss to not thank Dr. Polsides and Dr. Liu and all the other individuals involved in this study. Thank you.